Elizabeth, and this is my knee trigger. I have my console set up for all my knee projections that I will be doing, my AP knee, lateral, medial, oblique, tunnel, and sunrise. My ballpark technique for these projections are around 60 kV to 65 kV at 4 mass. Ready to go get my patient. Amanda?
Yes.
Hi, how are you?
Good.
Good. My name's Elizabeth.
I mean,
I'll be
not
taking
really,
you back.
because I hurt my knee.
Okay.
Running. Jogging.
Ooh, okay, cool. All right, so come on in. May I verify a couple things first?
Sure.
What is your full name and date of birth?
Amanda Marie Torres.
Okay, date of birth, please.
11382.
Perfect. All right, and not to offend you in any way, but is there any chance you can be pregnant?
No.
No? Okay, go ahead and have a seat on the table, on this table. A little further down. And go ahead and lie on your back. Head on the pillow. Okay, so I understand you're having knee problems.
Yeah.
Which knee is this?
It's my left knee.
Your left knee. Okay. So I will be detenting the tube to the table bucky, 40 inches. 40 inches there. Okay, so this is your left knee, correct?
Yeah, the damn biker ran right into me.
Okay. So go ahead and flex your knee, flex your foot. The center will enter half an inch inferior to the apex of the patella. Just going to cone in a little. And because I noticed that the distance from her as is to tabletop is less than 25, I will have a perpendicular beam. I'm going to put some heavy lead shielding on you so that we protect you, okay? Here we go.
It's really heavy.
Yeah, I know. It's good though. It's good protection. I'll put my left marker on her left lateral side. And we'll go ahead and stay still, okay? Beep. Okay, go ahead and relax. I'm going to set up for my second projection. Now I'm going to come over here and change it from an AP to an oblique projection, medial oblique. Technique staying the same, 60 to 65 kV at 4 mass. Now, Amanda, is it possible for you to rotate your leg inward? Help you.
Sure.
So medially. We're rotating the entire limb medially, 45 degrees, right about there. Center ray is still entering half an inch distal to the apex of the patella. About there. Have my left marker still on, right there. Okay, go ahead and stay still, ready to shoot. Beep. Okay, now that I have done my AP and my oblique, I'll change it to a lateral knee. And ballpark, again, is 60 to 65 kV at 4 mass. Okay, Amanda, great job. I'm going to remove this for just a second. Go ahead and lay or roll over facing that wall. So you're going to lay on your left side. Perfect. I'm going to place this back on you. I'm going to go ahead and angle my tube 5 to 7 degrees, cephalic. And I'm going to flex her whole entire leg about 20 to 30 degrees. Are you doing okay?
Yeah.
Okay. And center ray will be entering 1 inch distal to the medial epicondyle. My left marker right about there. Okay. Ready to take a shot, hold still. Beep. Okay, I'm gonna set up for just hold still. Okay, now I will be doing my tunnel view, also known as my Camp Coventry method that I chose. My ballpark technique is again staying 60 to 65 kV at 4 mass. Okay, Amanda, so I'm going to have you roll onto your stomach. Is that possible? Gentle. Okay, perfect. So this is still your left knee, correct?
Yes.
Okay. I will have you, I'm going to take the tube angle off. Remove this. My tube angle is about 40 to 50 degrees, and then we'll be approaching her knee flexion 40 to 50 degrees. I have this lead shield for you again, Miss Torres. I haven't forgotten about it.
Oh, thank you.
Now that I have shielded, I'm going to go ahead and grab my 8x10 cassette and place it under her knee. Go ahead and raise your left knee. Drop it down. Thank you. And go ahead and flex your knee up. I'm going to be placing this little device to help us keep it. Oh, sorry. I know it's difficult, but we just need to get these for the doctor. Okay. So now that I have placed that, center ray is entering mid-popliteal surface. This is still her left knee, so I'm putting my left marker on. Okay, I'm gonna go ahead and expose. Are you okay right there? Just hold still for 1 second. Beep. Okay, go ahead and relax your leg. We'll take this from you, and I'm gonna go ahead and run my film. Lift your leg. Thank you. Now that I have another 8x10 cassette, I've changed my console to my Sunrise, also known as a set of gas method. My ballpark technique is again 60 to 65 kV at 4 mass. Okay, Miss Torres, hopefully this is the last image. I'm going to go ahead and have you lift your knee again. Drop it down. Now for this one, move it over here. I'm going to go ahead and angle the tube about 15 to 20 degrees. And Ms. Torres, I'm going to ask you to flex your knee just enough to get this view. Okay, perfect. Stop right there. So now that I see that her patella is perpendicular to the IR, I will be honing in. Perfect. You're doing great. So here for the center ray is entering mid-patellofemoral joint. Okay. And we'll be putting my left marker on there. Okay, go ahead and stand still. Beep. Okay, now that I have it exposed, go ahead and lift your leg up. All right, you can relax your foot. I'm going to go ahead and run this film, and we should be done. We're done. For the criteria for the knee, here is our AP projection of the knee. You should see proper collimation, an open femoral tibial joint space with interspaces of equal width on both sides of the knee is normal. The knee is fully extended if the patient's condition permits. Patella should be completely superimposed on the femur. No rotation of the femur. Slight superimposition of the fibular head if the tibia is normal. Soft tissue around the knee and bony detail surrounding the patella. On the distal femur. Oblique with projection of the knee with medial rotation, you should see proper collimation, tibia and fibula separated at the proximal articulation, the posterior tibia, lateral condyles of the femur and tibia, both tibial plateaus, an open knee joint, and margin of the patella projecting slightly beyond the medial side of the femoral condyle. Is our lateral projection of the knee, medial, lateral. We should show proper collimation. The femoral condyles should be superimposed. An open joint space between femoral condyles and tibia. The patella is in the lateral profile. Open patellofemoral joint space. Fibular head and tibia slightly superimposed. Knee flexed 20 to 30 degrees and all soft tissue around the knee. For the PA axial projection of the intercondylar fossa, Kemp-Coventry method, you should see once again proper collimation, an open fossa, intercondylar eminence centered in the open femoral tibial joint space. Apex of the patella should not be superimposed in the fossa. Soft tissue in the fossa and inner spaces and bony detail on the intercondylar eminence, distal femur, and proximal tibia. For our tangential projection of the patella, the Sadagas method, you should see proper collimation once again, the patella in profile, a nice open patellofemoral joint space, surfaces of the femoral condyles, and soft tissue of the patellofemoral articulation. And that is a wrap.